Okay, so I'm going to talk about having the capacity to assess and optimise patients before treatment of prostate cancer. Some disclosures. So at Guy's and St Thomas's, we've had a service called the Geriatric Oncology Liaison Development Service for about, almost 15 years now. So I'm going to talk you through the journey of how we set up the service, but also so that I can demonstrate some of the key principles that any service can do, whether or not you have a specific geri-onc service. The whole point of GOLD came through a pilot which was funded by the Department of Health in a joint collaboration with Age UK and Macmillan, where a number of centres across the UK were piloting different ways of delivering this thing called CGA, that's Comprehensive Geriatric Assessment, or the prostate cancer nurses at our trust call it the MOT centre to patients. But basically what we do in these services is assess and optimise older people for appropriate cancer treatments. Now, we see patients of non-surgical cancers treatments, and the reason for this is we already had a very well-established surgical liaison service. The key principle of this is that we optimise patients for different treatment types, and I'll go through a little bit more about how we do this. Off the back of those pilots, the UK Cancer Strategy has recommended that we should be risk assessing using CGA in pathways for older patients undergoing cancer treatments. And in fact, now we are not the only service in the UK. This is a map of services in 2020, and since then, more and more services are popping up across the country. So how do we approach this? Well, we have referrals from oncologists, but we also have screening pathways from the wider oncology MDT, because it's important to note that not just the doctors are able to notice problems that may be occurring. Some of the MDT pathways use a screening tool that you can see underneath, where it gives a structure for identifying wider issues. We then see patients in clinic who've been referred or have been identified, and we use the same screening tool to avoid us asking questions where the patient doesn't have particular problems. The assessment is an MDT approach, so we have nurses, physiotherapists and occupational therapists. And this isn't just to help better define fitness for treatments or identify vulnerabilities or the goals, but really it's about looking for scope of interventions in specific context of the stressor that's about to come. And these optimisation plans can either optimise and improve fitness, can anticipate and mitigate against certain toxicities, or at the very least reduce the impact of toxicity and improve support. So what do we do? So we address what you might think about for a geriatrician, which is comorbidities and medications. And we look at that specifically in the context of the drugs that are going to be given. And I'll demonstrate that a bit more as we go through. We look at other things such as mental health, anxiety, depression, geriatric syndromes such as falls, their functional capacity to cope with the stressor to come. And that not just relates to their physical function and their resilience, but also to other factors such as nutrition.
Okay, it's only me.
In terms of fatigue.
I did have big breath here. Sorry. I was talking about those patients.
Oh, just one sec. So once we've seen patients in clinic, we move through and optimise their support plan and communicate with oncology in terms of how we're going to intervene and how we're going to re-review. In terms of GOLD interventions, what are the sorts of things that we're doing in clinic? Well, quite frequently patients have fatigue or anemia or nutrition, or have difficulties with abnormal tests. So, for example, we might find hypothyroidism or diabetes because it's the first time they've been screened for this in the context of ADT. Managing bladder issues is clearly quite common in prostate cancer. Identifying cardiac issues in a quarter. So there's a significant number of interventions and issues that you can identify if you proactively look for these things. So you might say, well, this sounds all very nice and fancy, but, you know, what's the evidence that this is going to change outcomes? Well, from some of our early work, we found that by doing this approach, more patients complete chemotherapy as planned and fewer require treatment modifications through cancer treatment. In terms of RCT evidence, because I know oncologists are a stickler for RCT level evidence, over the last 2 or 3 years, there have been several studies demonstrating that this CGA approach will reduce toxicity, improve quality of life, reduce delays, and people get admitted much less frequently. Now, I've been doing the gold service for about 15 years now, and the treatment landscape for prostate cancer has completely changed. And I guess we're all learning how to manage different drugs and how that may impact on different patients. So we have a few pathways for prostate cancers. It's not all about chemo or no chemo. We have a pathway just for patients on androgen deprivation therapy because these drugs have significant toxicities. These drugs have significant impact on long-term health. So actually having a proactive approach for this group is actually really important so that when they do get to the position that they progress, you've got them in a better position at the outset. ADT has lots of issues, and bone health is not just important around fractures when people have been on ADT for a long time. Even just a few doses for a 6 months of hormones with radiotherapy will impact on their fracture risk. When you think about ARTA, there are several different things that I think about when seeing patients in clinic to mitigate. So things like blood pressure, this frequently becomes a problem. And often in older people, I'm a bit looser around my targets. But when I know you're going to give an ARTA, we become much more proactive about bringing the blood pressure down so that it doesn't impact on treatment. Looking at why people might have swollen ankles already so that you can mitigate the impact if people get swelling from the drugs. Ditto around cognitive function. If we don't know whether there's cognitive issues at the start, it's very difficult to know whether or not ARTA has contributed to a problem. With abiraterone, you have to give the prednisolone, and I think a lot about diabetes and the impact on existing or newly steroid-induced diabetes. There are other risks around, for example, fatigue, and we have specific management pathways for managing fatigue, both with physiotherapy and occupational strategies, but also identifying other health factors that may be contributing, because fatigue is almost always multifactorial. And I also think about muscle and bone density loss, not just related to the hormone therapy, but through aging, but also the risks that ARTA themselves may bring. When you look at the use of ARTAs, more patients fall than if they don't receive the drug. There is obviously the hypertension issues. And actually, when you look at fractures in people who have ARTA compared to just having ADT, you will get more fractures. So actually, once you're on double therapy, you really need to think about bone treatments for osteoporosis prevention. We also have a radiotherapy pathway because the radiographers are often they're seeing patients every day for radiotherapy, and they notice things. Patients tell them stuff, and actually they need a pathway to move their concerns, which are often not necessarily just about the cancer. Things that commonly come up is around fear of incontinence and public transport, the financial cost of coming to hospital for several weeks. Do we always ask proactively in treatment planning whether the patients can afford to get there? Sometimes, particularly for older people, they have caregiving duties, and that can impact on their enthusiasm to whether or not they feel able to come to clinic every day for their treatments. Simple things like arthritis or COPD, which may not particularly affect their daily lives, but it might impact on their ability to lie flat and still for treatment. Now, we're probably, I can't even remember the last time I saw docetaxel in the last few months. So I think we're seeing this less commonly, unless it's in triple therapy, and probably most of those are not patients who'll be coming to a geriatric oncology service. However, I thought it was useful to still include because it's a good, particularly if you do more than one tumour type, it's really good to think about the supportive medications that we give with chemotherapies. If we're giving steroids in pulsed ways, we have to think about how do we proactively prevent hyperglycemic toxicity. And it's not just about the diabetic patients, it's about non-diabetic patients, and creating a framework to be able to identify these risks before it becomes grade 3, grade 4 toxicity. So now you must be thinking, blimey, that's nice, but you know, we don't have that, so that's a bit unfair, really. And you're right. There are increasing numbers of services coming around the country. So there's about 22% of trusts in the National Prostate Cancer Audit had some geriatric oncology services, but not broadly across all of the trusts within their area. And you might think, and I think that actually in this current financial climate, how on earth could you implement these quality type interventions? And I guess my answer is about creating frameworks to empower yourselves to do as much as you can. It's not all about having geriatricians, because there are many things that I do that I'm sure you can do it. It's just having the framework to remember to do it when you're busy thinking about other things. So what is that framework? So I think that's mainly 2 steps. The first thing is to actively screen for issues outside the cancer. And I guess we do it to an extent with the health needs assessment, but actually a little bit more. So you might think something simple like the clinical frailty scale, which now many departments outside geriatric medicine are beginning to get their head round. It's just pictorial. It's a bit like your performance status. So you might think about something like that, but it doesn't tell you their problems. So I personally believe it's much better to identify what the type of problems an individual patient has by using something like a questionnaire that, like I've shown earlier. But you decide whatever will work in your service is the right tool. It's not about the evidence base. It's about what's usable and feasible in your context. The next bit would be, for the second step, is actually just creating lots of pathways for how you manage different things. That table box thingy on the right, that's how I do ADT assessments. It's not me being clever, it's just having a structure to making sure I remember to check for diabetes and everything else. Anybody can do that. The same for anemia or fatigue. You can just create different frameworks for when do you treat iron deficiency anemia with Ferinject, what should be you checking for with fatigue, like thyroid function, diabetes, etc. So I think all of you guys can do this. So in summary, I think you're all geriatricians. You just need to create a framework to do it. You don't need me. If you have the services, brilliant. But if you don't let that put you off. I think you can do it too. You can identify unseen vulnerabilities only if you actively look for it. Otherwise, you're reliant on the things that they actively give you the information that comes across in clinic. You can better assess and risk mitigate and for specific cancer treatments. So you have to nuance to the stressor. And although these services are coming across the country, don't let that worry you that you think that's not achievable in your local area. Just think, you know what, start small, test and learn, and scale up to context. And it can be just by simple flow charts that you use with your wider MDT. I'm going to stop sharing there.